All right, let's begin. This is a high-density review of the 2026 PAFLR Clinical Practice Guideline for Managing Oligoarticular Juvenile Idiopathic Arthritis. We will focus exclusively on core updates for immediate clinical application.
Here's our agenda. We'll start with the core recommendations and the crucial risk factors. Then, we'll cover uveitis screening and management. From there, we'll walk through the entire treatment algorithm: first, second, and third-line therapies. After that, monitoring and treatment withdrawal protocols. And we'll conclude with complications and adjunctive care.
So, Section 1, the foundational principles. These are the Class 1 recommendations that really form the bedrock of the entire guideline. The guideline mandates immediate patient stratification from the outset. For your non-risk patients, the initial therapy is an intra-articular steroid injection, with or without NSAIDs. However, for risk patients, you move directly to conventional synthetic DMARDs, and the guideline specifies methotrexate as the preferred agent. If there's an inadequate response in either group, that's your trigger to escalate to biologic DMARDs. And remember, adjunctive exercise programs are also a Class 1 recommendation. I can't emphasize this enough. Accurate risk stratification is the pivotal first step. It dictates the entire treatment algorithm, and it's especially relevant for managing uveitis, a critical comorbidity we need to stay ahead of. So, what defines a risk patient? Well, it's the presence of any one of the criteria you see here. We're looking for elevated acute phase reactants. That's an ESR over 20 or a CRP over 10. A CJET-ODIS score greater than 5 indicates high disease activity. An involvement of the wrist, ankles, hip, or TMJ also qualifies. And of course, evolution to the extended subtype, concurrent uveitis, or early radiographic erosions all place a patient in this higher risk category. For uveitis screening, the frequency is entirely risk-based, hinging on age of onset and ANA status. Your highest risk cohort, onset before age 7 and ANA positive, requires screening every 3 months. All other cohorts are screened every 6 months. It's a clear directive. Uveitis management follows a very clear stepped care pathway. The primary therapeutic goal is absolute absence of cells in the anterior chamber. For mild cases, local steroid drops are the strongly recommended first step. For severe presentations, you escalate to systemic therapy with methotrexate and an anti-TNF monoclonal antibody. In refractory cases, the conditional recommendation is to switch to a second anti-TNF, or after failing 2 anti-TNFs, consider tocilizumab or abatacept. And a critical point, do not attempt withdrawal until you have a minimum of 2 years of quiescent disease. All right, now we'll examine the first-line treatment algorithm, breaking down the distinct therapeutic pathways for both the non-risk patient cohorts and risk patient cohorts. Here is the complete treatment algorithm. For now, let's focus our attention on that upper green section, which details all the first-line therapies. As you can see, the initial decision point is the risk stratification we just discussed. This table provides the specific dosing guidelines for your intra-articular steroid injections. Note that triamcinolone hexacetonide is the strongly recommended agent, particularly for larger joints, due to its longer duration of action. The dosing is weight-based, but pay close attention to the specified maximums for each joint. So what happens when patients fail to achieve treatment targets with those initial therapies? We'll now transition to the management strategies for escalation of care to second and third-line agents.
Returning to the algorithm, our focus now shifts to the lower red sections. These detail the precise escalation pathways for patients who don't reach their treatment target with first-line therapies, guiding the selection of second and third-line agents.
Escalation to biologic DMARDs is strongly recommended as a second-line therapy after failure of methotrexate or intra-articular injections. The guideline doesn't prefer a specific anti-TNF agent. For third-line therapy, after an anti-TNF has failed, tocilizumab and abatacept are conditionally recommended. For disease extension in patients 2 years or older, JAK inhibitors are an option. But before initiating any biologic, screening is mandatory for latent TB and hepatitis B and C. And of course, live vaccines are contraindicated. Section 5 details the monitoring protocols. We'll cover the tools for objective disease assessment and the strict criteria for therapy withdrawal in cases of sustained remission. The primary composite score recommended for assessing disease activity at each visit is the CJ-ADAS-10, the Clinical Juvenile Arthritis Disease Activity Score, which assesses 10 joints. This is your key metric for tracking response to therapy. Here are the specific, clinically actionable cutoff scores for the CJ-DAS-10. A score of 1.0 or less defines inactive disease or remission. Low disease activity is between 1.1 and 2.5. Moderate is 2.6 to 5.0, and a score greater than 5.0 signifies high disease activity. These scores directly inform your treatment decisions. It's critical to differentiate between assessing damage versus activity. The J-ADI, or Juvenile Arthritis Damage Index, is for long-term monitoring of irreversible damage. In contrast, the CJODIS-10 assesses current, reversible disease activity at each visit, and it's what guides your immediate therapeutic adjustments. For patients in sustained remission, the guideline outlines a very clear sequential protocol for treatment withdrawal. First, the patient must maintain inactive disease, a CJ-10 of 1.0 or less, for at least 12 months. Second, if they're on combination therapy, you taper and discontinue the methotrexate first, over a 2-month period. Only then should you begin to taper the biologic DMARD by gradually increasing the dosing interval. However, withdrawal is not without risk. You need to know the key predictors of a disease flare after stopping treatment. These include a history of uveitis, baseline ANA positivity, persistently elevated inflammatory markers, and, importantly, ultrasound-detected subclinical synovitis, seen as a positive power Doppler signal. These factors must inform your decision-making and patient counseling.
In our final section, we'll quickly address the management of a key physical complication, limb length discrepancy, and summarize the strongly recommended non-pharmacological therapies.
The management of limb length discrepancy follows a tiered approach. Prevention is key, through early and continued use of intra-articular steroid injections to control inflammation. For a mild discrepancy of 1 to 2 centimeters, a contralateral shoe lift is appropriate, but for significant discrepancies, those greater than 2 to 2.5 centimeters, orthopedic surgical management, such as epiphysiodesis, is conditionally recommended. To conclude, we have 2 definitive adjunctive care recommendations. Supervised exercise programs conducted twice weekly are strongly recommended. Conversely, the use of herbal supplements, either as an adjunct to or as a replacement for standard pharmacologic therapy, is strongly discouraged. This concludes our review. The final question for you to consider is this. Based on the flare predictors outlined today, which specific biomarkers, including imaging, will you now integrate into your monitoring protocol for patients who are entering the treatment withdrawal phase?